So tell them if they can hear us, Chris.
Yes, okay, sound is sorted.
Is sound coming through?
Yes, thank you.
Thank you. Thank you, everyone. I'm going to start from the beginning to welcome everyone again to the National Health Laboratory Services and the National Institute for Occupational Health. The NIOH has been conducting a series of training sessions on COVID-19, and today marks our 25th training session. So we're very pleased to be conducting this session for you, the shop stewards and health and safety professionals in the main, on what are the implications of COVID-19 in the workplace. We endeavor to make training accessible to as many people as possible, and hence all our sessions are recorded and they are available on our website. The NIOH website is 0 rated by 9 major service providers. And if you go onto our website, you will see which are the service providers that have 0 rated us. On the website, you'll find a series of presentations, fact sheets, etc., that can be utilized in the workplace. But still, one of the challenges experienced by many participants was the issue of access to data. And so this week marks a very important milestone in our training delivery, in that data has been made available through a fund that was awarded by the Health and Welfare HWSETA. And this was done through an application in collaboration with the Wits Health Consortium, led by Mr. Segi Pillay, and the Department of Health, led by Dr. Berikis Nasami, as well as the COVID-19 outbreak team at the National Institute. So at this juncture, I want to extend our deep appreciation to these institutions for their leadership and cementing the availability of data for training purposes for this very important cause. As approximately 8 million workers return to work on Monday, your role as shop stewards and health and safety professionals is fundamentally important in the relations between the employer and your members, and being the voice in ensuring health and safety and well-being remains a priority for all workers. So we're glad to be doing this training session and working in collaboration with you. And I'd like to thank everyone for joining. And I'd like to thank our panelists who's going to be assisting with answering your questions today, as well as the presenters and the back-end office workers, the support staff that has been assisting in making this session a success. So I wish you a productive session, and I'd like to hand you over to our program director, Mr. Ashraf Rakely. He'll take you through the proceedings for the day. Over to you. Thank you.
Thank you very much, Tanusha. So, Tanusha, that's Dr. Tanusha Singh, who's also the head of our immunology and microbiology section here at the National Institute for Occupational Health. So, Glenn, if we could just quickly, briefly have those slides with regard to the NHLS and the NIOH. Thank you. So, whilst Glenn is busy preparing that, I want to remind all of you that you must use the chat box at the bottom of your screen. If I can just have that off for a moment, Glenn. When you do ask questions, don't ask questions in the chat box, this one over here, I think, if I'm pointing correctly. Please use the Q&A box over here in order to ask your questions. No comments in the Q&A, because that's where our panelist is going to answer your questions live, or we will also deal with it in the Q&A session if we have time at the end. If you want to make any comments, talk about issues like, you can't hear well, or other matters, please contact that one there. And we will have an email address for you if you have any matters. That is the Wits Health Consortium email address, if you've got any matters to do with your data applications and processing of that. So again, welcome to the National Institute for Occupational Health. Glenn, the slides. And we are part of the National Health Laboratory Services. And this is a brief slide, a few seconds on this. The National Health Laboratory Service, I think, is a very, very valuable public health institute that serves the majority of our population with regard to the issue of laboratory services. It's the largest diagnostic pathology service in South Africa. It serves 80% of the population. It supports not just the National Department of Health, but also the provincial departments of health, as well as has a resource of almost more than 7,500 employees and specialists running the labs and other services. Also, we have as part of that, the laboratories in all 9 provinces across 260 sites. This is an important resource. So for you as shop stewards and as workplace representatives and officials and office bearers of the trade union organizations, it's important to know that this resource is there, and you need to ensure that this resource remains have the capacity to assist the nation. And then it has a capacity of over 30,000 diagnostic tests that can be undertaken, but it's important to know that in the times of the COVID crisis we're facing, that we need increased capacity to deal with backlogs of testing. And then our sister organization is the National Institute for Communicable Diseases, who's leading as a key resource around the COVID-19 response, supporting the National Department of Health and the National Minister of Health. For ourselves, the NIOH, Glenn, the next slide, we have the NIOH, the organization that is now bringing this webinar to you in partnership with the Wits Health Consortium and with the financial support of the Health and Welfare HWSETA. Our services is demonstrated there on the slide for you, and you will get these slides, and they'll also be available on our website. Very critical, with those resources will be shared with you for you to go to and secure the information you need to make sure that your workplaces and all the relationships you have within the workplace with the employer and the employer management team members and the officials in your trade unions, that you can prepare well to ensure that all your workplaces is not going to be sites for the passing on of the infection of the coronavirus that leads to the disease COVID-19. We've got specialized services, and we have, just that slide again, Glenn, one moment. We've got specialized services that deals with training, information sharing. We've got 3 specialized libraries with librarians in addition to our websites, and this training webinar is part of that particular session. There's advisory services, and under the outbreak response, you've now met Dr. Tanusha Singh, who's the head of that outbreak response team here at the NIH, as well as the website resources. There's a wealth of website resources. She's informed you that it's 0 rated, and therefore if you go onto it via any of your service providers, the cell phone and mobile companies, you won't be charged for data if you go to the NIH's website. We also have what's it called, the hotline, which is important. Okay, I've been informed that we now have a good connection with the CEO of the Health and Welfare HWSETA, who has, we are glad, has through the Wits Health Consortium provided the resources for the series of online webinars, COVID-19 webinars. At this point, I'm going to introduce to you to Elaine Brass, who is the Chief Executive Officer of the Health and Welfare Sector Education and Training Authority, shortly the Health and Welfare HWSETA, who is based here also in Johannesburg in Bedfordview. Elaine, are you online?
You can unmute yourself.
Please, could you just unmute your microphone?
Good morning, everyone. Yes, I am online.
And we're going to take the slide down, and we can have your video project if you have your video camera on as well.
Okay, can you see me? Yes, there we go.
Thank you very much. Welcome. This is Elaine Brass, CEO of the Health and Welfare HWSETA. Thank you for joining us this morning.
My pleasure. Thank you.
Please proceed, Elaine. My understanding is that you are just going to give a welcome to our participants and perhaps just give an idea of the Health and Welfare HWSETA's involvement. Could you go ahead?
Yes, thank you so much. So this is just a brief welcome. It really is exciting to be able to address you this morning. This is one of the second webinars that have been launched, and as the HWSETA, we are very proud to have a partnership with the Wits Health Consortium. And we are absolutely privileged to be able to fund this intervention. This intervention will be rolled out to over 23,000 people across the country, mainly frontline workers, but we are also expecting to roll it out to other workers, to shop stewards. So we're really excited about that. And to also say that, you know, this type of training is absolutely essential. And this type of training is something that will actually save your life, will save other people's lives. So the material that has gone into the training has also been from a period of learning on how to actually keep us safe from the COVID-19 virus. And we are really excited to be part of this project, and we wish all the participants all the best in their workplaces as they take the safety measures back into the workplaces. And I thank the Wits Health Consortium for this opportunity for the HWSETA. Thank you.
Thank you very much. That was Elaine Brass, the Chief Executive Officer of the Health and Welfare SETA, that is the Health and Welfare Sector Education and Training Authority. And the reference she made to the learning we've done over the period of time, as Tanusha mentioned, this is our 25th COVID-19 webinar that we've been launched since the beginning or early March 2020. And it's covered a whole range of topics, and I'm not going to read the whole list to you, but just to indicate a few quick house rules and a few indicators. For you as the participants, because there are so many of you, unfortunately we can't open your microphones are muted. And a reminder, at the bottom, you have the Q&A bubble, the main bubble, where you need to please only type questions, no comments and no queries and so on. You may raise queries and comments in the chat box, which I think I'm hopefully pointing to now. Then we can answer that for you separately. With regard to any data questions, there is an email address which you need to email to, and we'll give that to you, and I'll also type it for you in the chat box. The Q&A box is where we can answer your questions, and it can move from the ask section over to the answered section. It's easier to manage your questions in Q&A. So please, you are muted, and you can see and hear us. Unfortunately, we cannot do that. For all panelists, we'll also mute the panelists, and please, we ask the panelists to use the chat section and only send to panelists. At this point, I need to say thank you very much and introduce to you the presenters from the NIOH, my colleagues who are the subject specialists. The first one is I'm not sure if we have any representatives from the labor organizations that is online. Okay, so I'm not sure if there's somebody who's going to speak, but please, you can just indicate in the chat box if there is a national representative from those labor bodies who had been in the planning meetings with the Wits Health Consortium and the NIOH representatives. The next presenter is Dr. Pume Ndaba. She's going to deal with COVID-19 and workplace preparedness. That's very important for you to know what needs to happen when people get into the workplace and needs to be placed to keep you healthy and safe, and to ensure that we don't become people spreading the virus back to our homes and the community. So there is a speaker from Nahawu. I just hope this is a national speaker, Kolani. Kolani, I'm going to ask my colleague in a moment to open your microphone. He must just first find you. The second speaker on the list is Mr. Warren Mallon. He's from the Department of Employment and Labor, who's going to speak to the topic, the required precautionary measures for COVID-19 in the workplace. He's also, for me, an excellent expert on the question of what happens when the Department of Labour and Employment and Labour's inspectors visits your workplace. And then finally, we have another colleague of mine here at the National Institute for Occupational Health, Dr. Odette Volming, who's going to speak to screening procedures and follow-up. Now, I'm going to hand over to my colleague, Dr. Ndaba, and then we can always connect with our... Okay, so that was Kolani, and I now missed that in the chat what your surname is. Kolani, are you there?
Yes, I am.
Okay, please, I'm going to give you 30 seconds. We are slightly over time, but you are one of the organizations from the Labour part who has, in partnership with the Wits Health Consortium and the National Institute for Occupational Health, planned all of these sessions. Please just from your organization, and hopefully I can say on behalf of the other Labour organizations, just a quick word from you.
Thank you very much, colleague. As you've introduced me, my name is Kolani Mdoda from NIOH. I must confess that we are overwhelmed with delight over the initiative taken by HWSETA to sponsor this great August event. This is a very important moment in our lifetime. We also want to extend this gratitude to Wits Health Consortium and NIOH. We really appreciate the commitment that you are giving behind and also making sure that you raise awareness. We also believe as NIOH that prevention is better than cure. And this is part of the initiatives that really are taking us forward to that dream in order for us to realize it. Dr. Pillay and your team were very much delighted with the commitment that you have been showing, even answering our queries, taking up our messages, answering our calls without any complaint. We are very much pleased with your professionalism together with the team that you are working with. On our side, we want to thank our members who came up in numbers and shown interest. We know there are clinches there and here and there with regards to issues of data and so on, but that the technical team is solving. And I heard you, Doc, saying you will actually issue out an email that people can respond to or raise their issues on outside this platform. For that also we appreciate and thank you very much. All the best and be safe, stay alive. Thank you.
I want to say thank you very much. So we've heard from all of the key stakeholders, and we also heard from Mr. Segi Pillay when he gave the introduction for our first session on Tuesday. So thank you to the NIOH representative for that. Just a final comment before I hand over to Dr. Ndaba, whom we will start in a moment, is that you will be receiving a certificate via the Wits Health Consortium administrators on completion of this session. We will provide you with the email addresses and contact details. Thank you very much. I'm handing over to Mpumi.
Good morning, colleagues. My name is Mpumi Ndaba. I'm from the National Institute for Occupational Health. I'm going to be presenting on the update on COVID-19. And this was a presentation specifically prepared for the shop stewards as per arrangements that have been mentioned before. The initial presentation was for the 26th of May. So today's session is actually, it's an exact duplication of the presentation on the 26th, although it's on the 29th. So from the stats point of view, the stats are as at that day. The slide has been presented. We are within NHLS, and I believe Ashraf has spoken to that. We are the NIOH. Ashraf has also alluded to the actual slide, what we do and our focus areas, and a little bit on how we do what we are doing. And currently what we are doing is based on teaching and training as a way of supporting occupational health practitioners. These are the websites that we use to source information. So our information is mainly based on these websites. It's very important that people consult with the reputable websites and make sure that they've got latest information update. So as of the 25th of May, we had just above 5 million global infections, and the deaths were about 347,000 and more deaths throughout the world. And coming closer home on the 25th of May, we had about more than 23,000 confirmed cases, about 481 deaths, and then there were about just around close to 12,000 recoveries. And the leading province was Cape Town at the time. I believe it still is, but it doesn't mean that there is any province that is not affected at this stage. So just a little bit on the background and overview on South African issues regarding COVID-19. We know there was a lockdown on the 20th of March, and after the lockdown was uplifted on the 30th of April 2020, we have moved from level 5, we are currently on level 4, approaching level 3. And what we know currently is that the spread within South Africa was initially travel-related, but now it's more horizontal or community-acquired spread. And of these, we are aware that there have been some occupational cases, that is, cases that have acquired infection in line with doing their work, directly through them doing their work. This is now currently health workers. However, we know that there are few workplaces that have cases that have been reported which are more workplace related or more horizontal community transmission, but in the workplace, which are not necessarily occupational. So these workplaces include the travel related workplaces. A few teachers were reported at the beginning of the outbreak, health workers, retail workers, correctional services, and mining. So a little bit on the background of the virus. The virus belongs to the coronavirus family, and this family of viruses is responsible for common cold, and it usually causes self-limiting upper respiratory tract infection. So it's normally referred to as a novel coronavirus because this specific type of the virus is unknown. It's also unknown to our bodies and the behavior, and even our bodies in terms of immunity. We don't have any immunity to this virus because obviously it's not known. So how this virus is transmitted? It's transmitted through direct contact, touching an ill person or a contaminated surface, but also droplet transmission where you inhale droplets which have been coughed up or sneezed from a person who's infected. And remember, as you cough or sneeze, the droplets are of different sizes. So the larger droplets fall to the ground within a 1 to 2 meter radius of the person within a few seconds. But there is some evidence that the smaller, finer droplets have potential to go further than 1 meter, or further than what we know. And what we also know is that people are more infectious when they are symptomatic. So some of the symptoms that we know, there's quite a few symptoms, but some of them are quite common than the others. So symptoms can include a fever, which may appear from 2 to 14 days after exposure. People may have a cough. There's also shortness of breath. There are other symptoms like, the sore throat and so forth, which now leads to, when we look for the person under investigation, these are the people that will have at least one of the symptoms as mentioned, the cough, sore throat, shortness of breath, or fever. But it does not mean that these are the only presenting symptoms. So most of the people who have been studied who've had disease, it has been found that at least 80% of the people who've had disease have mild or moderate disease, and which is more like a common cold or a flu. And then 15% of the people or cases that acquire the condition will require hospitalization or hospital admission. 5% of these cases become critically ill and require ICU, of which close to 2% die. So people with underlying comorbid illnesses, for example, pulmonary disease, elderly, immunocompromised, etc., have been found to be having the worst outcomes. So most of the people who were part of those who had worse outcomes are mainly people who are vulnerable or who've got comorbid illnesses or other chronic illnesses that are further compromising them. A little bit on isolation and quarantine. When we talk about quarantine, we talk about when somebody who's asymptomatic for a period longer than the incubation period of the disease, or somebody is asymptomatic, they separate themselves for a period slightly longer than the incubation period of the disease. So this is why we talk about 14 days. But isolation, on the other hand, this is the person now who's symptomatic, somebody who's already ill, and they separate themselves from other people to ensure that the disease is not transmitted. So with quarantine, you are asymptomatic, but during that time you are monitoring so that you check if you develop symptoms around that time. Whereas with isolation, you already have symptoms and you already have disease, but you're trying to ensure that you do not transmit it to the other people. There's currently no vaccines for COVID-19, as you know, and there's no specific treatment for the disease, but it's more supportive therapy and monitoring. It could be in hospital setting or non-hospital setting. A little bit on updates with regards to the surfaces or the persistence of the virus on different surfaces. So the virus itself has a fragile membrane, and it's less stable in a number of environments. And the survival time depends on various factors, namely the pH. pH refers to, whether something is acidic or it's non-acidic, like soapy medium. And then the inoculum size, the size of actually like what has been coughed out or as the person was sneezing, the dryness of the environment where the inoculum landed, and then the temperature as well in that area. But most important is the exposure to disinfectants, and then also type of surface. Why the disinfectants are important is that we know that common disinfectant, for example, those that have 70% ethanol and bleach, can kill the virus. The next part is, what is important to mention is how long does the virus last on different surfaces. On the diagram below, you can see that if it lands on an aluminum surface, it has a potential of being there for at least 2 to 8 hours. And if it's a steel medium, it's 48 hours. Wood, 4 days, paper, 4 to 5 days, glass, 4 days, plastic, 5 days, as well as surgical gloves. This is the period during which it lasts should it not be cleaned, which is why we talk about the frequency of cleaning of these surfaces. So when we're at the workplace, when we talk about COVID-19 and sources of exposure at the workplace, it's important that we remember that some people will have acquired COVID-19 from the community or from the contacts that we have other than from the workplace, but also there's likelihood that through contacts and so forth, there can be other people who will have acquisition through the workplace, who will acquire the virus or will be exposed to the virus in the workplace. So the workplace, it's very difficult when you're now in the workplace, what comes from where, which is why it's important to set processes and ensure that there's no cross-contamination amongst workers in the workplace. In workplaces, we know that some workplaces have started working again. People have returned to work, but people return to work either from post-lockdown or after isolation, even during the lockdown or after the lockdown, or some people were on quarantine, they're coming back to the workplace now, or people might have been away from the workplace for a number of reasons. It could be from sick leave, it could have been on maternity leave, or you could have been on just leave and you're coming back to the workplace. Remember, you are finding people who come from also different sides and you don't know who has what. So it's very important for the employees to consider, awareness and readiness, or be ready for COVID-19 or to know about COVID-19 in the workplace, is that they have, as I've said, there's a risk of exposure. And in terms of being exposed, they might end up having the infection, which they might acquire from the workplace or from outside, or they might even transmit within the workplace, having acquired anywhere. There's also a financial risk because people are most likely to use their medical aid, sick leave to get help once they get the condition. But also, people who have no medical aid cover, they will end up having to use already overburdened public services. For example, it's not easy to know how long you will have to wait in the public health service, for example, even to consult and so forth. So those people might end up using maybe the whole day going to consult rather than maybe somebody who would actually make use of or utilize services or have access to services at a much more faster rate. So these are all things that we need to consider in the workplace. And also of important is the issue of asymptomatic workers who are also likely to transmit to others. And this could happen in the workplace platform. mental health issues, as people are very anxious in terms of what am I likely to acquire this? Am I at risk of acquiring from the workplace? As people are coming from lockdown, people know that they've actually reduced their contact with other people, but from the workplace, it becomes a new environment now as they come back. But also of note is people who already had existing psychiatric conditions, that they might get much more anxious, and these conditions might be much more worsened by either the lockdown or even anxiety of coming back to work. And also there will be other people who are coming back to work, for disability assessment or post having severe conditions. So these people will also need to be rehabilitated and accommodated in the workplace, and maybe even reorientated into the workplace with a new risk. So who are these workers in the workplace who are at risk of infection? It's very important to know that every person may be at risk of exposure to COVID-19, and as we said, from the workplace. However, there are other people who are at much more risk because of work. So those who are working in areas where they're interacting with persons and that may be potentially infected. But also there are other workers who might be immunocompromised because there are other pre-existing chronic conditions, for example, asthma, diabetes, heart disease, cancer, kidney failure, and any other disease that might not be on the list, but your medical or your attending doctor will have an idea and will know if that condition is potentially causing an immunocompromised status to your body or not. So some of the other workers now, because of the occupational nature of their jobs, include the airline workers, airline operations workers, border control workers, healthcare workers, laboratories, pathology and funeral services, solid waste, carers and teachers. But in general workplaces, other than the workplaces already mentioned under occupational, there are other categories that might be exposed. For example, persons interacting with people, as we've mentioned, teaching staff, cleaners, security workers, transport people, canteen and tuck shop workers, maintenance staff, and visitors to the workplaces. So for workplace to know now who is at risk and how we can help in terms of before we know what measures we could put in place, it's important that we consider, thinking back again, in workplaces we've done risk assessments, but for this instance, it's very important that we go back to the risk assessment that we have done and actually consider reviewing the hazard identification and risk assessment process. Because having mentioned the workers that are at risk, even within the same job, different workers have different risk exposures based on the specific job and specific risk assessment. So it's still important that in different workplaces we go back and ensure that we understand the new or updated risk assessment that are to be done. So some of the means that are there to mitigate the risk in the workplace. It's important that the workplace is almost like a community now where people are going to come together. So the primary prevention measures refer to what we do to minimize the risk of transmission in the workplace before there's transmission. So we need to still do health risk assessment, including identifying controls in place. Controls are means that are put in place to ensure that the risk is minimized. So these include, some of the controls are engineering controls, administrative controls, and PPE, which my colleague is going to talk to later on. But also while we do primary prevention, we go back to look at business continuity needs and pandemic preparedness. So we look at what we normally do or what we usually do and look at are there specific risk factors that could be identified there in line with the risk assessment. What do we normally do, or what do we still need to do, and how can we ensure that as we do that, we are prepared for the pandemic, we also have the prevention measures in place. Of utmost importance is educating and training people in the workplace, as well as recommending that health promotion is enhanced. Because remember that even though the only issue is not COVID-19, there are people there are vulnerable people with their pre-existing conditions. So health promotion will cover that over and above COVID-19 in terms of how it's important for you to manage your condition, whatever your condition is, and how your condition interacts, as a risk factor or is interacting with the likelihood of acquiring COVID-19. And some of the other preventive measures that can be taken into consideration in the workplace are secondary prevention and tertiary prevention. Secondary prevention refers to now that somebody has had is already at risk, or is for those who are going to come to the workplace, then we need to identify who is at risk, but also respond early. Or somebody who's had contact, for example, you've already had contact with somebody who's COVID-19 positive, and then now what should happen then? That is what secondary prevention talks to with regards to monitoring in the workplace and so forth. So some of the workplace changes that need to be considered are engineering controls in different workplaces. It could be reviewed, improved, or even introduction of new ventilation measures and natural and mechanical ventilation systems, depending on which workplace you are in, but also administrative controls, substitution, and PEE. Administrative controls means those controls that we can make sure that there's some sort of oversight or more like advice. But unfortunately, with administrative controls, they normally depend on the other person. So as these administrative controls are done, it's important that people remember that people in the workplace need to know about that, so that it's not just a one-way thing, because people will not necessarily comply easily if they don't know the issue or what's the point of introducing those administrative controls. So some of the administrative controls that are specific to COVID-19 include the importance of maintaining social distancing in the workplace, more office space, and even consideration for other people to work offsite, and also looking at facilities in the workplace, hand washing facilities, running water and soap. If not, is the means of hand sanitizing, means that will ensure that people continue with prevention measures for COVID-19 while in the workplace. But also some of the other activities or other facilities that could be looked into, like access control, avoid overcrowding in access control areas, and what should happen with staff and visitors or even other people who are coming to the work site. But also in terms of controlled access, we need to know who's within the facilities. So we need to streamline and ensure that there's controlled access to the workplaces that we work in. It's very important, as I said, to educate and inform workers. People must not be left behind. So with regards to informing workers, people need to understand that although we've heard about this in general community media or platforms, but we need to have communication platforms that are also accessible to all workers in the workplace, so that everyone can get information that is now specific to the workplaces that we are in. And people need to be informed of credible and relevant information on COVID-19. For example, the facts about the disease and how the disease is transmitted, an updated list of affected countries. In South African context, even affected, provinces and all the updated statistics. Also, the workplaces need to ensure that their latest policies regarding sick leave do incorporate or do consider sick leave mechanisms that are different, that have been considered specifically for COVID-19. And people must not be punished for staying away for flu. And as I said before, workplaces need to make sure that people are allowed, or it's facilitated and made possible for people who can work from home where feasible. And part of the training and awareness, we'll recall that in other workplaces, there have been people who remained behind, which we refer to as skeleton staff. So even the skeleton staff need to be sensitized of how many people will be coming back, what will be happening with people coming back, what about other measures that have been put in place? How are they going to incorporate other workers coming back? We need to be able to be communicating with staff at home, those people who are not at work, but maybe at home, they might be working or they might not have been working during this time, so that they are updated or they are appraised of the changes that have happened since they left. And also, in all these processes, the key operational people include human resource personnel, access control personnel. They need to be updated of the changes, as I mentioned in the previous slide. What procedures should people do when they come back? And what procedures have been reviewed or need to be reviewed? And also the issues of confidentiality and this being a public health outbreak. What procedures are going to ensure that confidentiality is maintained while we also observe that public health outbreak requires some form of information, disclosure, and so forth, and also to be able to manage an outbreak in the workplace. And health promotion I've spoken to. The key prevention practices that are worth mentioning, as we still need to emphasize the issue of practicing good hand and respiratory hygiene. People need to be reminded in the workplace and ensure that facilities are available for hand washing, but also avoiding close contact with people who are coughing, but also even in the workplace space, we have to be sure that in between people who are working and even visitors or public, we have to ensure that systems in the workplace make sure that the systems observe, the social distancing recommendation. People need to stay at home if they're ill. Workers need to know that, and there has to be mechanisms to say, if you have to stay at home, what do you do? Who do you contact? Who do you report to? And of utmost importance is to be able to wipe down all surfaces with a disinfectant. You'll recall from the other slide where we spoke about how long the virus stays on different surfaces and how the virus is sensitive to the disinfectants. I've spoken to the prevention practices. And now when people come back to the workplace, it's very important that there are screening mechanisms and identification of potentially affected employees. And also the workplace needs to be sure that it's rearranged such that there's limiting in contact and also movement of people. And the workplace needs to observe the social distancing. And people also need to be informed of the common practices, the respiratory hygiene, avoid touching their face, especially while at work. So as part of workplace preparedness, workplaces need to know, as we are reopening or as we're in the workplace, what's the anticipated number of staff or even the current number of staff in the workplace? When are we opening up services, and when are we opening even the services maybe to the public? Because you find that some of our workplaces are employee public shared spaces. So maybe in the meantime, there could have been people who were just employees preparing the workplace, but what are we going to do as we start to open up for the public? And also what's also important is the risk assessment. Now we look at these areas and the risk in terms of the risk of transmission, the operations in the workplace, what are we doing, activities, and of utmost importance is to consider the shared spaces. So some of the workplace practices that we need all to review include, let's think of the mass gatherings, the meetings, the meeting areas, the common areas, workstations like coffee stations, the bathroom facilities, where there's a tendency for people to gather around. We need to review what's going to happen around these places. We need to relook at the waiting areas, the clinics maybe, and the places where medicals are done, because those are places where are within the workplaces and people might converge at the same time. Is there supposed to be means of actually ensuring that there's staggering of attendance there? The meetings, the forums, is there a way of having meetings, using online platforms or meetings in a bigger room with fewer people? But also some of the specific procedures that need to be respected, access control, as I've alluded to, and public spaces, which are also places which are workplaces for our workers. And as a way of ending, if there are any other questions, the NIOH has a service where you can email to info@nioh.ac.za for questions, workplace-related questions. But also we've got a hotline at the NIOH which is specific to workplace issues, which is written in red. Thank you.
Thank you very much. That was Dr. Ndaba. And dealing with the aspect of COVID-19 and workplace preparedness. I'm going to immediately hand over to our next presenter, and that is Warren Mallon from the Department of Employment and Labour, who's going to address the next topic of the required precautionary measures, those measures that keep you safe and healthy for COVID-19 in the workplace. Thank you, Warren.
Thank you, Ashraf. Good morning, everyone. My name is Warren. I'm from the Department of Labour. I'm going to be talking to you about what is legislated in terms of precautionary measures for the workplace in this time that we are living in. Okay, so that's just what the contents of the legislation is going to be. We're going to look at the legislative requirements, specific regulations and risk assessments, updating the risk assessment, what are the results of the risk assessment, the legislative control measures, control of exposure specifically, the COVID-19 outbreak, and then employees' responsibilities and the conclusion. Okay, so to start off with, the Occupational Health and Safety Act requires an employer to conduct a risk assessment. That is in terms of Section 8.2d of the Occupational Health and Safety Act. So that section of the Act states that the employer needs to identify hazards at the workplace. They also need to establish precautionary measures to protect the employees, as well as provide means for those precautionary measures. Okay, then this section of the Act is supported by Regulation 2 of General Safety Regulations, which also refers to a risk assessment in the workplace. Okay, so specific regulations and risk assessments in terms of occupational health and hygiene. So you can see on your left-hand side there's a reference to the Occupational Health and Safety Act. Then on your right-hand side there it indicates the 6 occupational health and hygiene regulations, as well as a specific regulation that talks to conducting a risk assessment. So you got your hazardous biological agents, Regulation 6, your regulations for hazardous chemical substances, number 5, noise and use hearing loss Regulation 6, ergonomics Regulation 6, lead Regulation 6, as well as asbestos regulations, number 7. Okay, so what these 6 regulations require is that the risk assessment be conducted on specific hazards in the workplace, specifically with regards to biological agents, noise, ergonomics, and those 3 domains of ergonomics, the physical, cognitive, and organizational, as well as chemical agents, which includes your lead and asbestos. Okay, so I've taken an extract of what the regulations for hazardous biological agents regulates in terms of what needs to be taken into account when you conduct a risk assessment. Okay, so what needs to be taken into account is those 5 requirements below from A to E. So the risk assessment must look at the nature and the dose of the hazardous biological agent, as well as the route of exposure. The second one is where the hazardous biological agent might be present and in what physical form it is likely to be. So that would be either airborne or droplet. Then also looking at the nature of the work, the process, as well as if there are any control measures and their possible failures of those control measures. And also need to include what effect the hazardous biological agent has on the employee or the person visiting the premises, as well as the period of exposure. Okay, so those 5 requirements are also repeated in the other regulations that I mentioned earlier, that also have set out requirements that must be looked at when conducting a risk assessment. So updating a risk assessment. There's been a lot of talk recently about employers need to update their risk assessment. So the regulations also state when a risk assessment must be updated. So the first one there is that when the assessment is no longer valid, when control measures are no longer effective, when there has been advances in technology or in science, which allows for more effective control methods, or if there's been a change in work methods, the type of work carried out, or the type of equipment used to control the exposure, or if there has been an incident or an occupational disease has been diagnosed in the workplace. Okay, so just continuing with updating the risk assessments. So it could be given that a lot of employers did not include COVID-19 in their existing risk assessments. So therefore, as it is no longer valid for the current situation in the workplace, it would need to be updated. Okay, so employers, while they're conducting this review of the risk assessment and updating it, they should also look at looking at other hazards which might have arisen as a result of the outbreak. Some examples there are new chemicals could be introduced into the workplace, specifically with regards to cleaning and disinfecting. Employees might be now exposed to additional stress and anxiety and depression. They could be working longer hours of work or fewer hours, and they could be experiencing burnout. There could be additional manual handling that wasn't previously in place, as well as awkward postures, as well as the prolonged use of personal protective equipment. Okay, so the results from your risk assessment, these are just some general control measures results which can come out of the process of conducting a risk assessment. So we can start there with monitoring. So that would be quantitative assessment of the workplace to see what the actual exposure to employees is to a particular hazard. Then the risk assessment should also have control measures which are specific to controlling the actual hazard, probably not general ones. Then you should also have programs that can prevent occupational diseases as well as injuries. Medical surveillance is another result of the risk assessment. This medical surveillance should be risk-based and not just a general, everyone goes for all medical tests. It should be based on what hazards an individual is exposed to. Then employees need to go for the given information and be given training on the hazards and what has been done by the employer in the workplace to control the hazards. Also specific procedures can be implemented, as well as personal protective equipment that can be used. Okay, so in those occupational health and hygiene regulations, there's a similar format which they all follow. So if you compare all 6 of them, they will have this similar structure. Also have to say that this regulations and the OSH Act is a minimum requirement. If the employer wants to do more than what is legislated, that is also beneficial as well. So all the regulations, they talk about information and training. So what is important in that regulation is that it stipulates the contents of the training programs that employees must be given, as well as there must also be constant supervision of the employees in the workplace. Okay, that supervision is not necessary only from a supervisor or from the employer. Employees and health and safety representatives, as well as shop stewards, they also have a responsibility to supervise their fellow employees. Okay, then all the regulations also have duties of those exposed in the workplace. This is for employees, visitors, as well as contractors have responsibilities, and this responsibilities are in line with Section 14 of the Occupational Health and Safety Act. Okay, then there is a regulation that talks about a risk assessment or assessment of exposure, as well as monitoring. So as I said previously, the monitoring is with regard to a quantitative assessment to determine actual exposure levels. And also just take note that some monitoring needs to be conducted by an approved occupational hygiene approved inspection authority. Okay, then all the regulations talk about medical surveillance. Okay, so the medical surveillance talks about a baseline, a periodic, and exit appropriate medical examinations and tests. This will be depending on what hazards the employee is exposed to, as well as information from the occupational medicine practitioner. And as stated previously, the medical surveillance should be risk-based and not a general one-size-fits-all. So what that implies is that if you're only exposed to noise, you should only go for audiometric testing and not necessarily lung function tests, because if you're not exposed to a hazardous chemical. Okay, then just continuing, records need to be kept. So it stipulates that the risk assessment, monitoring reports, medical surveillance, and training records need to be kept by the employer. Also says for how long. So the risk assessment, monitoring reports, and medical surveillance, they need to be kept for between 30 and 40 years, depending on the regulation. And then the training records need to be kept for the period of employment of that employee. Okay, the control of exposure, that talks about the hierarchy of controls. I'll get onto more detail on that in the coming up slides. And then personal protective equipment and facilities. So this refers to all personal protective equipment, not only masks or respiratory protective equipment. And it states there that the PPE must be capable of preventing exposure. It must be correctly selected and fitted for the individual and properly used and stored. Note there is that PPE does come in different sizes, so it shouldn't be a one-size-fits-all for all employees, as we all differ in terms of our body dimensions. Okay, then information and training must be provided on that personal protective equipment, and then it must be kept in good condition and effective working order. Okay, then the last two requirements in terms of the regulations is that there must be maintenance of control measures, equipment and facilities. So it's no good just an employer providing control measures and then letting them not continue to work how they were supposed to work. So there need to be maintenance conducted on them so that they are in good working order and continue to reduce exposure to employees. And also the regulations require that there are special tests and examinations of specific engineering controls that need to be also conducted by an approved inspection authority, occupational hygiene. Okay, then there's also prohibitions where it talks about you may not use compressed air for cleaning any surface or any person, as well as you may not eat, drink or smoke or keep food or beverages in areas where there's exposure to particularly hazardous biological agents as well as hazardous chemical agents. Okay, so getting onto more detail about that one regulation that talks about control of exposure. This control of exposure looks at the hierarchy of controls. Okay, so it starts with the hierarchy of controls, always starts with you try to eliminate the hazard before it gets into the workplace, or you substitute it for a less hazardous hazard. Then you put in engineering controls, administrative controls, and then finally personal protective equipment. Normally it is a combination of these control measures which are best effective. For example, with the COVID-19 outbreak, an engineering control is having a well-ventilated room. Having administrative controls is reducing the number of people in the workplace. And then PPE is issuing of respiratory protection equipment. So those three controls together are making the hazard become as low as reasonably practicable in terms of risk. Okay, so this specific regulation in terms of control of exposure, it does require that the controls mentioned below need to be implemented where reasonably practicable. So that means that doesn't necessarily mean that they have to be done. If the employer, if they can't implement one control, they can move to the next one. But they must be able to prove why they are not able to implement the control. So it talks about limiting the quantity of the hazard in the workplace, limiting the number of employees exposed to the hazard. You can also limit the period of exposure, substituting for a less hazardous hazard. You can implement process separation, automation or enclosures. Then there's local extraction ventilation, that's putting extraction at the source of the hazard, or general ventilation, which is for airflow in the workplace. You have separation of different workplaces, and then access control to prevent unauthorized access to people in areas that they should not access, and then also developing workplace procedures such as safe handling, use and disposal disposal of items, maintenance, and well as cleaning. Okay, so with regards to the COVID-19 outbreak, the Department of Employment and Labour has released a COVID-19 occupational health and safety measures in the workplace. Okay, so I just have to state that this direction notice is not applicable for the healthcare sector. There, the Department of Health has issued guidelines for that sector, but this direction notice is applicable for all other sectors in industry, excluding those ones that are mentioned in the Occupational Health and Safety Act. Okay, so it talks about measures that need to be implemented in the workplace to reduce exposure to employees for the outbreak. So it looks at administrative measures, it looks at social distancing, symptom screening, then also sanitizers, disinfecting and other measures, and then the issuing of cloth masks, public access to the workplace, and then ventilation and other personal protective equipment. Okay, yeah, sure. Went back. Okay, so employees as well, it's not only the onus of the employer to implement Occupational Health and Safety Act, but the employees also have responsibilities in terms of Section 14 of the Act. So those responsibilities are that an employee must take care of their own health and safety, as well as others who may be affected by their acts or omissions. The employee needs to cooperate with the employer so that they comply with the requirements of the Act. They need to carry out any lawful order and obey the rules in regards to health and safety for the workplace. And they need to report any unsafe situation to the employer or to the health and safety rep. This, as I mentioned previously, that this Section 14 is also supported by the duties of those exposed in those 6 regulations listed below. So that's just referring to the regulation as well as the specific regulation. So it's Regulation Hazardous Biological Agents 5, Regulation Hazardous Chemical Substances 4, Lead Regulations 5, Asbestos Regulation 6, Noise Inducing Rust Regulations 5, as well as Ergonomics Regulations 4. So yeah, just in conclusion, so where to start is the risk assessment needs to be updated, not only for COVID-19, but also for other hazards that might be introduced. As mentioned previously, and what will probably be mentioned again, is that the risk assessment isn't just a one-person task. It's supposed to be conducted by a group of people so that you can gather as much information as possible. Then control measures need to be implemented in order to reduce exposure, and they must be maintained. And then the effectiveness of the control measures requires a collaboration between employers, union, and employees. So it's not just a one-person task, it's everyone's responsibility. Okay, thank you very much.
Thank you very much for that. And there you've had the representative of the Department of Employment and Labour's, that's Warren Mallon, dealing with the required precautionary measures for COVID-19 in the workplace. Our next speaker is Dr. Odette Volmink, and she's going to speak to screening procedures and follow-up. And just keep in mind, there's a difference between screening and monitoring and all those things. And so she'll explain that all to us. But a reminder, please, some of you have been typing your questions in the chat box. That's only for comments. Questions for your presentations, please type it here in the Q&A box. If you've typed it there, copy it and paste it in the Q&A box. We are only answering live and certain questions based on what's in the Q&A box. Thank you very much. I hand over to Dr. Volmink. Welcome, Odette.
Thank you so much. Thank you. Hi, good day, everybody. Thank you so much for the opportunity to share with the shop stewards today, because it's, their input is so valuable in this fight, as Warren just said. it's a collaborative effort between employers, employees, unions. It's the only way we're going to be able to tackle this outbreak effectively in our workplaces. So I'm going to speak to screening procedures that are required in the workplace. And I know that you guys are all familiar with this slide that was in Dr. Mpumi's presentation. And it talks to how can the coronavirus enter our workplaces and possibly cause infection to our workers. So the first one on the left-hand side, we see the door. So the one way of the infection coming into our workplaces is through people entering our workplace and who have now gotten community-acquired COVID-19. And then within the circle, one can also get COVID-19 infection from the actual workplace, from the tasks that are being done in the workplace, like healthcare workers who are looking after COVID-19 patients, laboratory workers who are testing specimens, and in those workplaces you can actually get it from the task that you are doing. And it's so important to mitigate the risk, because to prevent spread in the workplace, and as us as workers go back into the communities that we come from, to also prevent spread within the community. So these are some of the workers at increased risk for occupationally acquired COVID-19. And I know Dr. Mpumi spoke to this. Not only are the healthcare workers, people who do post-mortems and laboratory workers, but also airline operators, retail workers, people who work with the public, border protection, correctional facility workers, as well as the waste management workers, environmental health workers, but even people who come into our homes to repair our electricity, our plumbing, can be at risk of acquiring occupationally acquired COVID-19. And thank goodness, well, now with the ban on travel, but as bans are lifted, people who travel to high-risk places are also at risk of occupationally acquired COVID-19. But I said I'm speaking to medical screening. And just as a way of starting is, what is medical screening? And medical screening is designed to detect early signs of illness by administering certain tests to apparently healthy people. And the tests that I'm talking about include questionnaires, it could include a physical examination, it could include specific medical investigations, like blood tests and things like that. It's oftentimes a secondary prevention strategy when we're looking at workplace-acquired disease. So it's looked at trying to quickly find evidence of disease in people who are put at risk in their workplace, but it can also be a primary prevention tool, from preventing cases from even coming into the workplace to prevent infection within the workplace. Okay, Warren spoke to the director from the Department for Employment and Labour around how to have occupational health and safety measures within the workplace. And one of the things it speaks to is symptom screening. And the directive states that every employer must take measures to screen any worker at the time that they report to work, to see if they have any observable symptoms that could be possibly associated with COVID-19, which could be a fever, cough, sore throat, redness of eyes, shortness of breath, anything like that. They also require that every worker needs to report if they suffer from any of the additional symptoms. There may be less common symptoms like loss of smell or loss of taste, nausea, vomiting, diarrhea, fatigue, weakness or tiredness or body pains. And the directive states that it requires workers to immediately inform the employer if any of the symptoms occur while they're at work. So it asks for medical screening to be done and for employees to report if there's any symptoms that they experience. So in terms of medical screening strategies for COVID-19, there are most times there's two main strategies that employers or companies can use. One is a self-monitoring strategy where employees will be made aware of what kind of symptoms would make them possibly have COVID-19, and they would then need to monitor themselves for the symptoms. That is by either looking out for symptoms of a fever or taking their temperature twice a day and actively looking for symptoms in themselves. If workplaces employ the self-monitoring tool, then they need to have, employees need to be aware not only of the symptoms for which they need to report, but also who do they need to contact should they develop these kinds of symptoms in the workplace. Then there's active monitoring, where someone in the workplace regularly communicates with a potentially exposed employee to assess for the presence of fever or some other symptoms. And oftentimes is used for employees who have high exposure in the workplace. And continuous communication needs to be between either the occupational health department or the infection control department of the workplace and the employees to ensure that this is an effective monitoring system within the workplace. So these are just some examples of using screening tools, and these can be done a paper-based system, these can be done electronically. There are even some apps that people have made for phones where their employees tick off even before they come to work whether or not they have any symptoms that could possibly where they could possibly experience symptoms that could be present with the COVID-19 diagnosis. So these are some of the screening tools that can be used. So the types of screening commonly used in COVID-19, firstly is the symptom questionnaire, which these are examples of a symptom questionnaire. But in some places, temperature screening is also done, but this must be done with caution because it shouldn't be done in isolation. If temperature screening is used, it should be used alongside a symptom questionnaire because fever may be intermittent in some people or may not even be present in some patients like the elderly, the immunocompromised, or if people are taking fever-reducing medication like Brufen or Panado, these can mask these symptoms. And we don't want to do this because we're trying to screen so that people who are potentially infected can stay out of the workplace. So some of the recommended procedure. The first thing, I know Warren spoke to this, I know Dr. Mpumi spoke to this, is we need to do a risk assessment. We need to determine the risk of COVID-19 to our employees in the workplace. And as the directive directs us, is that at the start of the shift, we need to screen workers for symptoms that are associated with COVID-19. So now, should an employee report any of the symptoms? Ideally, if they're at home, they shouldn't even report to work. But if they're already at work when the screening occurs, they need to immediately be isolated from other workers, be provided with a surgical mask so that their respiratory droplets and secretions are contained, and they should be transported for further medical intervention. Then within the workplace, we need to assess the risk of transmission of that symptomatic person and need to disinfect the area where the worker made contact. then we need to wait for results and actively follow up the results of the employee who has been referred for a test. Ideally, this should be followed up by a health professional, given the ethical considerations and the confidentiality issues. And, you know, it needs to be ensured that if the medical practitioner, the occupational health nurse is the one that asked for the tests to be done, they need to ensure that notification is done to the Department of Health, because COVID-19 is a notifiable disease. If an employee is positive within the workplace, a workplace investigation should be done. And this would involve trying to find out where did that person, what are the movements of that person, who did the person who was positive, who else did they come into close contact with? Because it would inform contact tracing within the workplace, and will also inform where would specific cleaning and sanitation need to be done. It's also important as we deal with COVID-19, we realize that it's bringing a lot of anxiety, not only to people who don't have it and are scared of contracting COVID-19, but also for people who have who now have COVID-19 and have been diagnosed to be positive for this virus. They experience quite a bit of psychological stress. There's even issues around stigma at the moment. And so it's important to ensure there's psychological support for these employees. And if the COVID-19 infection is occupationally acquired, which we will figure out from the workplace investigation, this needs to then be reported to the Department of Employment and Labour, as well as the Compensation Commissioner. Okay. So this is just a different diagrammatic representation of what we said before, that if a person is positive, we need to ensure that reporting is done. They must be isolated in the workplace to prevent further spread within the workplace. And then we need to ensure that contact tracing is done within the workplace and appropriate cleaning measures is carried out. Now, when should somebody then come back to the workplace? Now, it's said that for mild cases, we know that 85%, the majority of cases will be mild, is that they can return to the workplace approximately 14 days after the symptom onset. But severe cases are not always that simple. Some guidance is that they can return to the workplace about 14 days after they're clinically stable. So if they needed to be on treatment, on oxygen, this would be 14 days after they no longer need to be on this kind of treatment, and there's no symptoms. Only then can they be returned back into the workplace. So I know we all know this picture again that talks to how can exposure come into the workplace, and we spoke a lot about screening and preventing the positive person or potentially positive person walking into the door. But we also spoke that within the circle of our workplace, we could be doing jobs where we come into contact with COVID-19 and we are exposed in the workplace. So this is a little bit of an algorithm about how the workplace management of workers who are exposed in the workplace to COVID-19. Oftentimes, when we're looking at a worker who is a healthy worker who is now being exposed to COVID-19, we need to classify the risk of exposure within the workplace. A high risk of exposure is when there's exposure, when there is a close contact with an infected person or an infected specimen. So there's a close contact, usually within a meter, for a prolonged period of time, so for more than 15 minutes, And when somebody is not wearing PPE, or there is a failure of their PPE, either the PPE, the mask was torn or something like that, that would then say it is a high risk exposure. Or if somebody, just say, some kind of a sputum specimen drops to the floor or drops on the table and somebody has direct contact with respiratory secretions, this would constitute a high risk of exposure. And these people would then need to be monitored. So if there is a risk of exposure within the workplace, the first thing to do is to try to ascertain, is this a high risk exposure or a lower risk? So if we've confirmed that it's a high risk exposure, this person would need to be self-quarantined. Cleaning needs to be initiated, and reporting needs to be done to the NICD because this is a close contact. Now, there's a slightly different guideline for essential workers versus non-essential workers, because with essential workers, we anticipate that at some point as the epidemic or the pandemic increases, we may have staff shortages within essential workers. So in most circumstances, when we have a high risk of exposure to COVID-19, self-quarantine needs to happen for 14 days. However, with essential workers, they need to self-isolate for a minimum of 7 days. And if there is absolutely no symptoms, during self-quarantine, a person is self-monitoring for any symptoms of COVID. They're monitoring themselves for fever. If after they've been exposed, they've been quarantined, they are monitoring themselves for fever, for symptoms, for all these things, and after 7 days, they have none of these possible symptoms, they can return to work after they've had a negative test for COVID, which can be done on the 8th day. Most workers, or the non-essential workers, basically the same thing has to be done. We need to do a workplace investigation. When we know there's been exposure, we need to classify the exposures at high exposure. This should be confirmed by the line manager, and then cleaning needs to be initiated, reporting needs to be done, and immediately this person needs to be quarantined for a minimum of 14 days. During this time, monitoring needs to be done. Monitoring for symptoms, monitoring for fever. Also, it's very important, we spoke about the mental health risks, and we need to ensure that there's mental health support for our employees. And they would, if they have no symptoms during this time, we know there's an incubation period of 14 days. So after 14 days post-exposure, they have no symptoms, they can return to work on the 15th day. Now, in the event of either the essential worker or the non-essential worker having any symptoms, they need to be prioritized for testing. So now we said that the first thing when some worker is exposed to COVID-19 in the workplace, we need to assess the risk. Is it a low exposure or is it a high exposure? We spoke to the high exposure risk already, but in terms of a lower risk of exposure, these are people who have had exposure to someone who is COVID positive, but they were at least more than 1 meter away. The exposure was for less than 15 minutes, or they were wearing PPE, so they were protected, especially respiratory PPE. And in the case where the COVID positive patient was wearing a surgical mask, that also lowers the risk as the secretions are being controlled at the source. So when a worker is exposed to a low risk within the workplace, it's important always to do a workplace investigation, ensuring that we have made the right category of risk and it's a low risk. This should be confirmed by the manager, the health and safety reps, and the whole system that's in place. And in those cases where it's a very low risk of exposure, these employees can continue to work but must self-monitor with regards to temperature and symptoms for 14 days. Like in the case of high risk exposure, anyone who presents with symptoms during this time needs to be referred for testing. So now we're going back to the cases where we have an employee who is positive within our workplace. And we've done all the things, we've done workplace investigations, and we have managed the workplace, and the employee has been managed medically as well. But now the question is, when do these employees return to work? The CDC offers us some guidance on this, and they say that two strategies could be used. We could either employ a test-based strategy, where an employee can only come back to work when they have full resolution of the fever and they're no longer using fever-reducing medications to control their fever, but their fever has stopped. And also, they no longer have respiratory symptoms. And on top of that, they have a negative test for COVID done at least by two consecutive swabs done more than 24 hours apart, and they're both negative, then an employee can come back into the workplace. That is one strategy that could be used. However, it's important to note that given our circumstances with regards to the number of testing kits that we have, it may not be the best and most practical strategy to employ. But there's also, we have guidance on a non-test based strategy. And by using this non-test based strategy, we can use where there are issues of testing asymptomatic people because of limitations in testing. The non-test based strategy says that a person can return to work at least 3 days or 72 hours have passed since they've been recovered, in terms of they don't have a fever without using any fever-reducing medication, and they also don't have any respiratory symptoms. So 3 days after that, they can come back to work. But they also, 10 days has to have passed since the symptoms first appeared. Okay. So basically, people can't come back to work in under 10 days, but also they must have no symptoms for at least 3 days, and then they can be safe to come back into the workplace. But on returning to work, either after a period of isolation, if somebody's been positive, better, and then coming back to work, or if they have been quarantined because they have been exposed, there should be some general work restrictions that should follow. Ideally, someone should undergo a medical evaluation, particularly in someone who's previously been positive, to confirm that they are fit to work. They should also wear surgical masks at all times while at work for a period of 21 days. Most workplaces need to wear surgical masks anyway, so that this sort of will follow suit. They need to implement social distancing measures, as they did before, ideally, and they need to adhere to hand hygiene and respiratory hygiene and proper cough etiquette. They need to continue monitoring for symptoms. And if any symptoms recur or even get worse, they need to seek medical reevaluation. In cases of healthcare workers, it's ideal that healthcare workers who are COVID positive coming back into the workplace should avoid contact with severely immunocompromised patients initially. So workplaces need to ensure that there are protocols in place for dealing with the event of a symptomatic person and how they can be referred for testing and treatment, for isolation, and how they're going to do contact tracing in the workplace. We also, within our workplaces, need to have protocols with regards to how to deal with an infected positive employee and how to bring them, how to return them back into the workplace. We also need to have policies and protocols in place with regards to social distancing, hygiene, and all these other preventative measures within the workplace. So it can't be stressed again that communication and awareness of our employees around issues and around symptoms, around treatments, around what controls are in place in the workplace for COVID-19 is essential. We need to review the health risk assessment now looking at this new risk within our workplace. We need to look at all the hierarchy of controls to ensure that we have things in place. We need to screen daily, and no mass testing is recommended. We should test the symptomatic people, but screening is essential. We need to minimize the risks by socially distancing, thorough regular hand washing, not only for staff, but also the contractors, the visitors, all other people who come on our sites. We need to ensure respiratory hygiene is done by all these people as well. We need to avoid touching our faces, especially while we're working. And workers need to be empowered on self-assessment, on symptom reporting, on what sick leave policies are in place. We need to create an environment that is blame-free and that allows people to come forward. We need to decrease the stigma that's associated with this disease, and we need to ensure that we are protecting people's confidentiality, but putting things in place and screening and contact tracing where we need to do this. We need to encourage and insist that symptomatic people stay away, self-isolate. And we should have occupational health input to manage our program internally effectively. Thank you so much for your time. My colleagues also spoken to this workplace queries. We have info@NIOH.ac.za if you'd like to put through a health and safety query around COVID-19, or there's a hotline if you want an immediate response. Thank you so much for your time.
Thank you very much for that, Kate. We are now going to have our Q&A session, so you may just want to move your chair backwards and join us. I will adjust the camera. Warren, for yourself as well, and comment. So, thank you very much to our panelists. They've dealt with the key topics. So we just need to do that. Just make sure that we all one moment, I think, well, that's me, I think. Okay, so thank you very much. We've dealt with the COVID-19 in the workplace preparedness, the required precautionary measures for COVID-19 in the workplace, and the screening procedures that Odette has just done. We have been answering some of your questions live in the Q&A chat box, and we are now going to deal with as many questions as possible before we close. So, we're going to ask our colleagues in PWA just to share with us one of the first questions. If I have so the question asked here is, if the office is being fumigated or sanitized, how long must we wait before we use the office? Do we have a sense of that requirement?
I think it's very much dependent on what chemical is being used to actually sanitize the office. I think that ideally the manufacturer's instructions, you know, the MSDS that comes, or rather the SDS that comes with the chemical that they're using, should give some kind of guidance. But I think it's also important to note that these are chemicals that we're using with regards to cleaning. And so these chemicals in themselves can be harmful to you know, people that come into contact with those chemicals. So it's important for the cleaners and whoever's doing the fumigation or the sanitizing to have the windows open, to ensure there's good ventilation, so that not by combating one problem, we're creating another problem. So just to bear these things in mind.
So clearly we're dealing with a biological hazard, and now a chemical hazard may be introduced, and dealing with that is effective. Do you want to come on there?
Yeah, also in addition to what Beth said, it's also how well it was done as well. So yeah, whoever's doing the cleaning and disinfecting, they need to be supervised to make sure that they're doing a correct job and actually doing it, because if they're not doing it properly, then they haven't properly cleaned it or something.
Okay, so we heard Warren there with regard to making sure this is done very properly. Also, there's a difference between your general daily cleaning that is required and your general daily disinfecting by your support staff in your workplace, and the sort of deep cleaning that's sometimes required when people are actually just removed from the workplace before they can return. So your risk assessment will indicate both what you deal with COVID-19, the biological stuff, and it should also address the chemical hazards. And then, as we indicated, clearly your safety data sheets will indicate what the time frames are and engage with your cleaning service provider around this. So the next question that we have is dealing with the procurement of disinfectant, which are not having labels showing contents inside the bottle. Is this transparent and the person is not sure what is inside? Is it likely to be a mixture of water and pure spirit? So this sounds like your hand sanitizer.
Yeah. So it is legislated that chemicals need to be correctly labeled. Recently, there's the introduction of a global harmonized system for labeling, but that isn't quite legislated yet. But there is still legislation that talks about chemical substance needs to be correctly labeled with what the content is. It is also legislated that chemical needs to be bought with a safety data sheet as well. So if those haven't been received from the supplier, whoever's purchasing the sanitizer or cleaning agents within the company, they need to then request it from the supplier. And the safety data sheet must have at least 16 points, otherwise it's not valid safety data sheet.
Yes. So it's critical for you as workplace representatives or training representatives, as defined in the Labour Relations Act and shortages in your constitutions, that you consult also with the health and safety representatives and the health and safety committee about what are the measures and steps and procedures in place, and you've had the recommendations from our colleagues. So I'm going to read one of those questions directly from the Q&A, if one has been asked to stay at home for 14 days and told to come back to work after those days, does the employer have to send someone to see if the employee is no longer sick before coming back to work?
Now, this is for quarantine.
Well, it's the 14 days. I'm not sure if that is self-isolation. Clearly, the person seems to have been sick, so they will probably a positive diagnosis.
So in the cases where the person is positive, most times positive people are usually symptomatic at this time. I think it's good practice Well, firstly, they have to be out of the workplace so to prevent infection. But it's good practice for the employee and the employer to maintain contact, to see how the employee is getting on, how are they doing. Oftentimes, you know, depending on the severity, they would have seen a doctor as well, and so medical certificates, you know, would be given to the employee for the employer. And so it doesn't need that the employee would have to physically go and look. Oftentimes a medical certificate would be issued, just like in a flu, if you've gone to see a doctor and they say, okay, you can be off for three days, this would be appropriate for the workplace. So it would work similarly. And people know the public health regulation, sort of the public health requirements in terms of how long people need to be off work, and so we give appropriate signals.
So clearly, if there's been a positive test, you don't return until there's been a negative test.
No, there's two ways. You don't return, you can return to work. I think you need to continuously contact your employer, but after you're sick, what the guidance has said, there's one is that you have to have a negative test, but another one guidance is that now if you're no longer symptomatic, so say you're no longer symptomatic, you've had 5 days, 6 days of being horribly sick. On day 7, you're no longer symptomatic. You need to be able to return to work if after day 7, 3 days after you're no longer symptomatic. So just that now equals 10 days, and at least 10 days have lapsed since your first symptom. Then you would probably, a doctor would say you are fit to work. But ideally, people should be visiting their doctors to see whether or not they're fit.
And in your workplaces, I think you need to be very clear about these guidelines, as has been explained. Your cooperation and clear dialogue between yourself, your members, your employer and employer's representatives, and especially the health and safety representatives and the health and safety committee, those conversations must be happening in your workplaces if it's not already happening. I'm going to go to the next question unless something else to add. So, who should be the medical evaluation, who should do, apologies, the medical evaluation for someone who's been on self-quarantine as this person has never been seen by a doctor? That's from Siboye. So there's been no diagnosis, there's been no consultation with the doctor. What is the advice?
You know, these are very tricky things to navigate. So I think especially within workplaces where, you know, oftentimes our policies are such that we require sick notes for this, we require sick notes for that, in order for these things to happen. But I think now we need to make policies within our workplaces that are a little bit flexible, because there are times where Mpumi could potentially, I'm so sorry to use this example, but she could be a positive person, and I'm now in contact with her. I don't have a mask, I'm not practicing any social distancing, and now she is my contact. And according to the public health guidelines for our country, I now need to self-quarantine. And so if those public health guidelines are being fulfilled, we need to have policies and sick leave policies in place that take into account those public health guidelines.
Okay. You want to add to that?
Yes, I wanted to say, like Dr. Odette has said, there are guidelines that are there, but remember when it comes to workplaces, COVID has come, we've had some existing procedures and protocols in the workplace. So the presentations were about how do we look at updating existing policies, you know. So the example of self-quarantine in the workplace, there would have been some change in the policy now to say, because there's this option of self-quarantine, how are we as this specific workplace going to deal with that? So it's very important that, yes, in the beginning, things were happening haphazard, but by now there should be, those the sick leave policies, that's the work attendance policies that we're talking about. Remember, a lot of workplaces, people have never had to work from home for a long time. So that is what the workplace needs to work on how do we develop new policies moving forward, on when you're working from home, how do we report and so forth.
Okay, thank you. So another one of the unanswered questions that we want to deal with is, sometime during the briefings by government, it was mentioned that surgical masks must be used by healthcare workers and non-healthcare personnel, and public should wear cloth masks. As I'm listening here, surgical masks are mentioned always. Shall we accept surgical or cloth masks from employers?
Can I just answer one part of it? I'm sure somebody else will. In terms of the surgical masks, I think in my presentation, we spoke a lot to surgical masks as when we have somebody with symptoms in the workplace. I think when somebody has symptoms within the workplace, we know that surgical masks, just like we use them when we were operating, they contain secretions so that it doesn't go to the patient, that you're operating on. So it holds secretion. So my surgical mask is protecting for me, and my surgical mask is protecting Ashraf, not so much protecting myself. So when we have a person who's potentially infected in the workplace, when we're screening, we have somebody who's symptomatic, or we have, we will then cover them with the mask, the surgical mask. So we should have some available, particularly for those cases, because it's protecting. We do have other regulations that talk to cloth masks.
Okay, so I don't know if there's any guidance with regard to cloth masks?
I think also what was also mentioned was previously there was a shortage of PPE in the country, so didn't want people wearing PPE and taking it away from those that really need it. So it comes down to also the risk that the person is exposed to. So your healthcare worker is probably more at risk than the general public out there. So that's probably also why it was advocated that way, why some people must use the surgical mask and others must use the cloth mask. Also, there are better types in the surgical mask out there, which other employees might need to use because of their working situation as well. So these are just the minimum that has been mentioned through government communications out there as well.
And just one addition, don't forget that the mask is just one element of the containment measures, that you have a combination of the containment measures, as all of our presenters have indicated in their presentations. So even if you work as a cashier in a supermarket, there would probably be a perspex screen also between you and your client, apart from a visor and a perhaps cloth mask. So the N95 and surgical mask would definitely not necessarily be recommended for the retail worker in that particular sense. Okay, so the next question is the question of I work for the Department of Health, and we've not done any deep cleaning of the office spaces, yet we have been operating at 100% staff since the announcement of the lockdown. Is wiping of walls, doors, and surfaces on a daily basis effective? What is the process of deep sanitizing? Okay.
Before actually we get to deep cleaning and deep sanitizing, I want to sort of take the person who asked the question back to the risk assessment. We keep on talking about the risk assessment, but this is basically saying, look at your workplace, look at the current hazard, and look at what's the risk, who's likely to be exposed, and all of that. So before you decide on what we do next. So in terms of the deep cleaning of the offices and so forth, it might not be necessary in your workplace, might not have been necessary. It doesn't mean that everything must be shut down and deep cleaning. But moving forward, the issue would be, like we said, look at whatever, the frequency of cleaning rather, and what a cleaning material or the detergents and disinfectants that you use for cleaning. So people need to really understand what deep cleaning is, what does it do, and is it really recommended? Because now the issue is, as we go back to work, we look at the activities there. I'm not sure where in the Department of Health. It could be a hospital, it could be a theater, it could be offices where the person works. So that depends on the risk assessment for the area that you work in or work with. Obviously, hospital will not be the same as offices, and even within the hospital, the tuck shop will not be the same as theater, and casualty will not be the same. So each area needs to have specific recommendation and policy or practices for that specific area. What cleaning material are we using? How often are we using, and so forth?
Generally, it sounds good that you're doing daily cleaning and deep sanitizing if you've had actual positive cases in those particular areas, and it's probably more appropriate for those parts of the hospital where the COVID-19 patients are also being dealt with. The next question is it normal detergent chemicals that should be used for disinfecting, or is there specialized chemicals? I think again we've answered that earlier by dealing with either the department responsible for cleaning in the workplace or the contractor, and to have that engagement. Keeping in mind that in your workplace there are specific people. In hospitals, it's going to be the infection prevention and control officials and health and safety people, as well as your health and safety committee people, that must play a role around this. And whoever that COVID-19 manager is that is being appointed in terms of the regulation, please have conversations with them as well.
Just to say, sorry, Ashok, that there are some presentations that have been done around cleaning that people can look at.
Yes. So please go to the website www.nioh.ac.za, nioh.ac.za, and it's 0 rated. What is the standard procedures for disinfection for COVID-19 section? What must they be used? I think we've covered that, and we've also referred you to the website, because the specifics around chemical agents for disinfecting and desanitizing is covered there. A compliment saying that this is indeed an eye-opener. Thank you very much for that. HWSETA. From Henry Fasaki, are there a list of comorbidities to assist our members going forward, and for learners to assist them also? Comorbidities. We've covered that in our presentation, but maybe it's useful just to repeat that, just in case Henry has missed that.
The list of comorbidities is long. Some of the conditions are common, some are not common. So what we've said of the common conditions are asthma, we've said diabetes, we've said hypertension, we've mentioned immunocompromising illnesses. For example, in South African setting, we know TB, there's high prevalence of TB, there's, people have HIV infection and so forth. Those are just comorbidities. But remember, what is important is the control. Is it controlled, is it not controlled? And also the other issue with comorbidities is that sometimes it's not just one condition. It might be one condition that is not controlled, but also it might be a combination if you have two or more, or with other factors, of other conditions. For example, age above 60, it's not really a comorbidity, but that is also, when it comes into, when there's another comorbidity, then it's sort of it weighs higher than somebody who's just 60 alone, or somebody who's got a specific comorbidity. So the list is not sort of exhaustive, because there are other conditions that people know. I have this sort of rare condition and it works this way. People who have those conditions, their doctors will know that this is an immunocompromising illness, or maybe for this time you are on this treatment for something else, and that treatment renders you immunocompromised just because you're on that medication. So at that time, it's not like the condition itself is making you, is a comorbidity that is sort of considered in our list, but because you're on treatment for that condition, then maybe you're immunocompromised.
Okay, I'm going to go for the very last question because we've reached time. There is a question regarding compensation. Also on our website, we do have the session, video and audio, and the presentations that deal with compensation matters. Please visit the website. With regard to the N95 to be recycled, we can give you a specific response on that. We will definitely get back to you on that. But for now, I'm just going to take this question. Are nurses over 60 years supposed to work in an isolation where there is COVID-19 suspects or positive patients? The follow-up point made here by the same person is, nurses with uncontrolled chronic illnesses, are they also supposed to work in isolation where there is suspect or positive patients in COVID-19? Let's see what that is our last question.
It's a general question. I know to the person who asked the question, it sounds very specific. sitting here it's very difficult because I don't know the controls in your workplace. So I'm going to take you back again to the issue of risk assessment. Yes, it's an isolation ward. Yes, it's a COVID-19 ward. But as I'm sitting here, I don't know what controls your workplace has put in place to make sure that there's optimized prevention in your workplaces. However, the nurses over 60 years, I'm assuming that there should have been some sort of consultation or some consideration to look at you are over 60, what else and what so forth. But also they should know like if they're allocated there or not, or maybe the process is still going to happen where they might need to be moved to another area and so forth. So workplaces have been advised because the issue of vulnerable workers is more of a recent issue. Some workplaces are not aware of that, but it's good that we look at the guidelines currently, if people are over 60, and then we look at who else is in the environment, what can be done and so forth. But there's a lot of controls that need to be in place, and if it's a hospital environment, the assumption is that there are also a whole lot of other places where they could be maybe deployed to or moved to, but maybe that is still in the pipeline. But if everyone in that, let's say in that area was maybe over 60, maybe it's more of a temporary measure to hand over to new people and so forth.
Okay, so we have reached the end of this particular session, and once again, thank you very much for the work done by the Wits Health Consortium. One moment again, with the Wits Health Consortium, as well as the support from the Health and Welfare HWSETA. I also just need to say thank you then to the representatives, that is Mrs. Sagit Malay from the Wits Health Consortium, and Elaine Brass, the CEO of the Health and Welfare HWSETA. And my colleagues here on the panel, that's Dr. Mpumi Ndaba, sort of in the middle of your screen, and our camera is distorting it. We are all sort of approximately 1.5 to 2 meters apart, but it's like your rear view mirror, but the image is not the same as what the reality is. So also that's Dr. Mpumi Ndaba, and then Warren Allen from the Department of Employment and Labour on your far, I think your far left. Next to me here, Dr. Odette Volmy. They both are from the occupational medicine sections here at the NIOH. And just to remind you, I'm going to quickly flip on the screen, please, Glenn. These are the resources. It is also going to be available on our website. Please, the website is 0-rated, and that's the one right at the top, www.niih.ac.za. As workplace representatives, if you can just go there, thanks. Please consult any of these websites. If you've got specific questions, there's this hotline there that says NIH OHP hotline 800-111132. Please contact us there, but it's easier if you email us, and you'll see at the right at the bottom right-hand side corner, email us at info@nih.ac.za. That's the list of resources that will be available also on the website and as part of this recording. And then if I can quickly take you forward, that's what the website looks like. All our resources are there. It's taken over our landing and front page. Right? And then that's some of the tabs you can go to, resources, the COVID-19 resources, the fact sheets. And these are the list of some of the things that are there, the next one. And there's more tabs. Please go to the website. You're not going to be charged data longer on. And that's some of the fact sheets. Next one. And these are the frequently asked questions that we have here. So some of your questions have already been dealt with as well. And then there's the training videos, both in audio and in video. So thank you for that. And at this point, I need to say thanks to all of you. You have a very important role to play as workplace representatives. It is important that you now use all this information and ensure that there is a dialogue in your workplace. And as I said in the last session, COVID-19 is not going to ask you what union membership you have, or if you're manager or employee. It's going to require all of our cooperation, dialogue, and conversations to ensure that our workplaces don't become sites of super spreading of the COVID-19. I'd say thank you very much to you, and you will receive future notifications of the other sessions that has been sponsored by the Health and Welfare HWSETA. From myself, Ashraf Rekram, the National Health and Safety Training Manager, on behalf of the National Institute for Occupational Health, goodbye.